Hello, everybody, and thank you very much for taking time out of your busy days to tune in with us to this second series. I'm just going to wait for about 10-15 seconds to let people log in. Sometimes it takes a lot longer than we think to log in. I certainly have that challenge more than once every day. So welcome again, and we'll just give about 5 more seconds and then we'll start. All right, this is our second of our series in mental health care and primary care. The first one that we had very recently was with Senator Dr. Mohammed Ravalia, a family physician from Twillingate, Newfoundland. And if you didn't have a chance to see that, it's on the YouTube channel somewhere. I'm sure you can find it. This second session, I'm really looking forward to as well. It's about training and supporting healthcare workers in primary care. And we're really pleased to have two outstanding clinicians, thought leaders, and wonderful people participating in this. Alexa Bagnell, who is child and adolescent psychiatrist and the head of the Division of Child and Adolescent Psychiatry at the IWK Hospital and Dalhousie University in Nova Scotia. And from the other coast of Canada, the Vancouver coast, where they always brag that spring comes much earlier, Dr. Bruce Hobson, who's a family physician. And he has had extensive experience in leading this kind of work with Doctors BC and is the medical director of the University of British Columbia CPD program. So welcome, both of you. Thanks for being here. And this is an important issue because, primary healthcare is the foundation of our healthcare system. And too long, it has been siloed from mental health care delivery. So people would go to the primary care physician for every other aspect of healthcare, but not get the mental health care that they needed to be part of holistic, integrated healthcare. So I'm just going to open it up. Maybe, Bruce, you can start. What are your thoughts about this? How can we enhance the capacity of primary healthcare and the workforce in primary healthcare to deliver care people need?
Thanks, Stan, and welcome everybody. I appreciate having the opportunity to be able to speak to you about some of my thoughts, and they are my thoughts and built on my experience in there. And I think, Stan, you've touched on one thing about the silos. It's not only to patients, but also to healthcare providers. It's not only looks siloed, it looks chaotic. And it's really challenging for not, again, just the patients, but the care providers to navigate. And so, I think a key thing that we need to do to manage this is to focus on the patient-provider relationship and on the continuity of care that a primary care provider provides, and do that in a collaborative environment where we're talking about working with teams, where we're offloading some of the work that has traditionally fallen on the shoulders of the primary care provider, but they now say they just don't have time to do, and have others be able to be involved in that. So, it's recognizing that problem and identifying not just the needs of the patient, but the needs of the primary care providers in being able to deliver that care is really critical, especially in mental health.
So I'll add in, it's really wonderful to be here, and I love hearing Dr. Hobson speak. He's been such a leader in this area nationally and has international claim as well in terms of some of the programs and interventions and ways that he's thought about this, because it is what I call a complex problem, because our system really wasn't designed to work well together, unfortunately. And now we really are trying to work well together because the identified need in mental health is so large that we know if we don't work together, we will not be able to really provide the supports. Obviously, I'm a child and youth person, so I'm going to say child and youth, but supports across the board for mental health care. And we rely a lot on our primary care colleagues And I think the demands on primary care are pretty phenomenal, I will say, and sometimes growing. And so I think of how do we support them the best? Like, how do we become accessible? So as a specialist, because I think there is a feel of like, okay, well, the specialists are here, primary care is here. And, you know, whenever specialists are done, it goes back to primary care, whether primary care feels that they can manage that or not. How do we actually work together around that patient, family, and support together and be pulled in instead of it's, you know, you're moving here and then you're moving here and then you're moving here. The journey for a patient is quite disjointed, as Dr. Hobson said. And so you don't have that continuity they're feeling, but you don't have the great communication, and you can be left with primary care really feeling like, okay, now we're holding the ball. So, I mean, I can say some of the things that I think about, like we have a lot of innovation that's happening across the country, a lot of flexible thinking. And how do we get that so that people are doing that across the board, like using, you know, e-health and like ways that we can book online for consults and using telephone consult, which, you know, old school telephone consult, but booking that and but creating it in flexible ways that that primary care can really use. And then thinking about training. So beyond, as Dr. Hobson said, beyond physicians, like who is supporting in primary care and how do we bring them in to share like our either our consult evidence-based treatments, what they can do in practice first, what they can be trying that we know works before they reach out, or even things that we can give them that support and they know who to call back when they need more support, but they're managing in primary care and not needing to sort of send in and then wait. And I think that really would build capacity, and we've seen it work. We've seen a lot of new innovations. Stan knows about the Learning Link that we've launched in Nova Scotia, where you bring people in virtually. So primary care providers, they can be family physicians, nurses, clinicians, social workers, whoever's supporting that child and family, bring them into the room, the virtual room, so they can be a part of that appointment, part of that conversation, which really helps in that collaborative care, shared care model, but without needing to be physically in the same space, which time-wise is very hard for busy clinicians and people in primary care and specialty. So I'll stop there and move it over to you guys, but it's such a great area and there's so much neat stuff going on right now in the country.
You know, and I think one thing you touched on, Alexa, around the need to develop programs is certainly one of the things we recognized here in BC 25 years ago when we weren't seeing people go into primary care. Now we're seeing kind of the opposite. We're seeing a whole bunch of people leaving primary care and not filling that void as quickly. That what we needed at the policy and at the strategic level was partnerships. And so, you know, about 20 years ago, the Medical Association here in BC, the Doctors of BC, and the Ministry of Health actually formed a partnership to address that and actually collaborated and worked together, which is amazing. Especially, you know, I know in some of the provinces where it's a very antagonistic and oppositional kind of relationship, we really worked well together, and actually through the physician funding developed what we call the joint collaborative committees, one of which was the General Practice Services Committee. And that committee existed to be able to improve the access to care, to look at building physician capacity and coordinate system services. So you really need that system level framework to be able to address some of those frontline needs. And at the same time, be having conversations with the frontline workers, not just assume that the policymakers can know what's needed at the front line, and that you know, any one entity, there's that saying about nothing about us without us, that is just so critically important. And those collaborative committees were created to do that and start that kind of work.
You know, that's an important structural component of ensuring that everybody that needs to be together works together to create what is needed. And as part of that creation, I know, Alexa, in fact, you were involved with Bruce in creating some really interesting stuff, which was fascinating. Here you are in Nova Scotia creating stuff in BC. What a country we live in, right? So you want to share some of the work that you guys did together on that, and then now you've all gone beyond that too.
Yeah, it's really been. We started probably in 2007 or so, looking at chronic disease, and then moved to adult mental health in 2009, and then to child and youth mental health. I think it was around 2011 with you, Stan, and Alexa, looking at building educational modules with all those things in mind, influencing policy at the macro level, looking at resources and relationships and connections at the meso, the middle level, the regional community level, and then looking at integration of workflows and tools and resources at the micro, at the front line, at the clinic, at the family physician or care provider level. So, I think all those things were things that were important to think about. What policies need to be changed? How did payment need to change when you're delivering care? What kind of resources are needed in the community to be able to support that kind of care? Because as a primary care provider, nothing would drive me more crazy than to know what the problem was and be able to identify what the patient needed, and then try to access the services that were needed for that patient, and they weren't there. And you'd go, and there's nothing that drove us crazier, and it's nothing that contributes to burnout more than being frustrated like that. But we worked on those kinds of things to look at, what educational tools were needed, right from some of the things that you helped us provide, Stan, around assessing kids with depression in adult mental health, looking at things like simple tools like PHQ-9 and disseminating them and spreading them and standardizing them and figuring out how to get them into EMRs, and then figuring out how, once they're in EMRs, that people could find them and make use of them in their workflow in the day, not just say, here's a tool, go ahead, use it. So, I think all those things, which I go into more detail on, but Alexa, I'd love to hear, your thoughts from that perspective of what you contributed as an expert from your end.
Yeah, what I loved about what we co-created is that, I was coming in kind of new to this idea of policy and thinking more systemically, because I was always thinking, oh, let's create this education. But, you brought in the systemic part, which is for anything to be maintained, it has to be supported at all levels from a model perspective. And, creating content isn't enough. And that's why I think this model has been successful, is it wasn't just content. Yes, we know what works and we can get that information out there, but if it's not supported across the system, there isn't a higher level policy, if it's not remunerated appropriately for people to have the time to work collaboratively, and the resources aren't present, it won't succeed. And that's why I think this has been so successful. The modules, I remember creating them and Senator Cooch actually pushing me a bit, because he said, well, family doctors and people in primary care, they can do cognitive behavioral therapy. And I'm a cognitive behavioral therapist in my training. And I'm like, you're right. And creating sort of basics in cognitive behavioral therapy, which is a great evidence-based tool for first line for anxiety and depression. And what can they do in the office? What are the key things? How do you distill it down? When do you know that you need to move on and consult a specialist? And knowledge is power, so to speak, but it's also really comforting to know, okay, I'm doing the right things. I'm doing something that's evidence-based. I know when to call for help, and I know what help looks like, and having those resources. I do think that the e-health world has been helpful in some ways in terms of people who don't have access to some of these evidence-based treatments. That can be a way that they get access. I mean, I know Strongest Families has been talked about before. It's a Canadian product where you can have telephone-based interventions that are evidence-based and for children, youth, and families. And being family doctors in our region, being able to access that is really helpful, because they know where to send people as that first step, and they don't feel that, oh, I know what you need and you're not going to be able to get it for a year. And that's a terrible feeling for any of us if we feel we're telling them something that they're not going to be able to receive. And so the more we can spread that, I think the better, the more access and innovative access, the better. And then measuring, I think the part of this project that was so great is we also measured all the way along what was working, what wasn't, adapted it. Was it what primary care was looking for? How was it working for specialists? It really was an ongoing, what I guess we call continuous improvement now, but at the time it was really an evidence-based looking at how this intervention was going to evolve. So I think, if we could spread more of that, I think across the country, I think it would be really, really helpful.
Yeah, and when you were speaking, Alexa, and thinking back to those times about how we work together, it was key, as I mentioned before, nothing about us without us. It wasn't just that the specialists and primary care providers were included. It was also the educators, because a lot of, say, for example, child and youth mental health happens in the school system. A lot of mental health issues happen in the judicial system. They happen in places outside of what we think about as traditional medical environments. And so in order to be effective and collaborative, we need to bring in the educators, the school counselors. We need to bring in the social service people, the actual even RCMP in some cases, to be able to have that conversation. And you touched on measurement, which is, I think back in those days where we had spreadsheets and we check off things and include things in that, and you realize, great idea, but then you're talking about, as a family physician, I would look at that and go, oh, more work. Oh man, what are they expecting to do? I go to this seminar and I'm going this webinar, I'm expected to do more, and then I've got to record it on a spreadsheet. So what we've done lately is looking at how does this fit in the tool that we're using that sits in front of our face in the electronic medical record, and how can you access those tools easily from that, and the electronic medical record reflects my workflow. So it puts in order those questions I'm asking myself as I'm being presented with and having a conversation with a child, an adult, somebody that's having mental health or substance use issues. And then when I'm presented with that and reminded that clinical decision support, how do I document it? So that not just that it's documented for medical legal, but that it's documented for quality improvement. And one of the organizations I've worked with as a medical director here in BC has been the Health Data Coalition. We're working on being able to extract information from the EMRs and present it back in a tool that allows the individual physician to look at their own data, to look at their own experience and say, where have I been? Where am I at now? And how has this change impacted the care that I'm providing? And then not only to look at it for myself, but compare it to others, because as adult learners, we work best in an environment where we're problem solving, we're working with others, we're being challenged by real cases. I think of one really excellent family physician who had taken, I believe, the adult mental health module and was using the PHQ-9, and then for some reason or other, it disappeared from where he thought it would be in his EMR. So he stopped using the PHQ-9. That basic little questionnaire that looks and gives a sense of what somebody's current mental health status is for anxiety and depression, or GAD-7. And so, being able to look at those things and make sure that they exist is really complex. And it requires a lot of people talking to each other and working together and reinforcing each other's activities with that common vision. And that just doesn't happen often enough.
But it can happen, and you guys made it happen. And what, I just want to reflect what I'm hearing. I'm hearing a couple of things that are really important. One is that the approach is systemic, and the importance of getting everybody, including people who are living with mental illnesses or need for mental health care, and their families, of course, at that table to sort these things out. I'm hearing that enhancing the training and the skill sets for healthcare providers is a necessary but not sufficient condition, right? And I'm hearing about the importance of ensuring that the workflow is measured and that it is used for continuous improvement. So those things are and they're doable. And both of you have worked in systems that are doing that. The other thing that I just want to ask about is if you're looking at a primary care practice, and I think Bruce talked about teams and group practices. I mean, they have a variety of healthcare providers in those practices. And all of them bring tremendous skill sets, and all of them bring scopes of practice that can interdigitate and support each other. If you're thinking about who has been left out of many primary healthcare teams, maybe counselors, maybe people with psychological skill, delivery, therapy skill, who else could be in the general and everyday primary mental health and primary care to help with the mental health care delivery at the system level?
I'll jump in on this. It's a great thought, because I do see primary care as very broad, and I think Bruce talked about it in terms of, there's a lot of what I'll call sort of different areas that we don't think of as traditional healthcare, but who are doing mental health interventions, or being faced with mental health people who are looking for mental health help. And we know that, like, schools, so Bruce brought up schools, but I think of schools actually in the primary care system. I know they're not primary health care, but they're delivering a lot of support in the schools, and sometimes are left out of the sort of treatment team. And we've worked really hard in Nova Scotia to bridge that and to work together and to have, even as basic as consent that we all agree on, so that a family's not having to, oh, well, no, so you have to go give consent here. Oh, that's a healthcare consent. You have to go, now you go to education, do an education consent. And oh, you've got community services involvement. That's a separate consent. So whenever you get those 3 pieces of paper signed, come on back like 3 months later. So being able to actually agree, which is the system level that Stan talked about, on a consent, so that we all accept it. And then we can just communicate, we can bring each other into the rooms, but really wrap around supports, and also think about what are we learning in our session that we could share with the school that they could then translate. And what's really cool, and Bruce and Stan have both done a lot of work in schools, and I'm very passionate about schoolwork too, is how quickly schools supports, like people who are working in this area, pick up skills and can then translate and use them and build on them. So it's like this exponential effect when you start to build these skills and capacities. It's not just around one kid. Like, it might start around one kid, but it gets translated into an exponential support that one intervention, one education, and then being able to have a place to go for further support keeps it going. And so we've really worked on that in Nova Scotia, of our education health collaborative, and it's made a big difference. Even just recognizing kids who are at risk and need more, and being able to not feel like they're sort of, okay, well, I'm going to worry alone. You don't have to worry alone. You actually know where to call, where to go next, and you actually can move someone into the right level, and then get support as they're going back. So it's a big area, but I do think the shared understanding of primary care is very broad. Mental health happens everywhere, and actually supporters are everywhere. They're not just in an office. They could be in a school. They could be in a community service office. They could be in a church. There are many places that they may be, and we have to think broadly about that.
And I think as you were describing that, Alexa, and talking about that shared understanding, a simple problem we ran into early on in child and youth was, how do we communicate? Because in the school, the fax machine is in the office, which is not secure, and everybody sees it. So you can't send medical information by fax to a school and expect it to get to a counselor. And conversely, in the mental health services, they are not allowed to have stuff go by email. So in one case, you got to send stuff by email to the teacher. or the counselor, and you got to send stuff by fax to the mental health service. And it's just like, so on a micro level, even that communication challenge has to be addressed there. And I think the other thing about being collaborative, it's not just collaborative between professions, it's collaborative in your own profession. So we created a community of practice here in BC around child and youth mental health, substance use, that brings in all those people to have continuous conversations, and look at how they can have an impact. And challenging thing is funding that and supporting that. And that's something, getting back to the very first comments made, that where that cooperation at the highest level of government and medical associations is really key, really key.
But that may be a case of pay me now or pay me later,
Yeah.
which is, which is a big issue, and it costs more later than it costs now. And one thing that BC has done, that I know of, through actually University of British Columbia, the Faculty of Education has championed mental health integration into schools. Most of the school districts in BC have trained the teachers, have trained the school counselors, they're linked with their primary care providers. And yet that's a model that sits in some places, but is not available in other parts of the country. How would you scale these successes from coast to coast to the rest of the country? How would you do that?
I think you're starting to do that right now here, Stan. Where people have to know about these things, so that they can connect with and contact. And, I think I work also as a peer coach and mentor here in BC, and we're now starting to have other provinces reach out to us to say, how are you doing your peer coaching and mentoring? How are you delivering that? How are you developing that? How are you supporting that? And I think we need to have more of those inter-provincial, national conversations that bring together not just the people at the strategic, that's where it usually happens, but bring together at the same room, in the same place, people that are working at those middle and frontline levels as well.
Alexa, I know you've done a lot of this. What are your thoughts on that?
Well, I do agree about the national conversations and having things like this where people are talking about, things that have really worked in their area. And then I was like, people are like, what? I didn't know you could do that. And so, it is, I think it's an ongoing conversation. I would say, sometimes people think, well, we don't have the resources, but actually a lot of the time is just using your resources differently, and it's not new resources. And I think that's important to know, so it's using time differently. It's thinking about, if I talk to, a group of family physicians and help them with this, then they're going to be able to do this for way more than I can see. And so thinking about how you divide your time up, and also about how people are remunerated around their time. So that's something we've worked hard in our province and are still working on is, if you join a collaborative practice, or if you join a call and you come into an appointment and you're learning about your patient and what you need to do, making sure that you can actually, be, remunerated for that time, because that's going to increase the ability for people to be participating in these sessions and collaborations. And then I guess the last thing I'd say is, use innovation. I think there's so many innovative ways to connect now, but don't forget the old school innovations as well. And, telephone works. And so there are, it's just remembering to use all the pieces. It doesn't work for when everyone uses something slightly different. So having lots of ways to connect is a really good model. So we've really, I call it, diversified our portfolio of connections in terms of ways we connect and are available to connect, because it isn't just one way, is what we've really found out.
Well, that's so amazing and so right on. And I like you to keep reminding us to use the phone. It actually works very, very well. And it is a rather old technology, but I don't know. I never used to carry I would have had a long cord from the phone I had as a kid, and my parents listening to everything I was saying. That didn't work well all the time. Well, look, I can't believe we're at the end of our time. But thank you both so much for being here and for sharing your message. Of not just of hope, but of the reality that this can be done. this really can be done. And if people are listening, I'm gonna ruin both of your days. I'm gonna say, look, reach out to Dr. Hobson and to Dr. Bagnell and find out how it can be done, because it can be done. And if we can enhance the capacity to deliver mental health care and primary care, we're going to make a humongous difference in the lives of every single Canadian. So thanks both again for being here. And to those that are listening, we're going to have the next session looking at the role of pharmacists in primary health care, some new and innovative ideas. I don't think they use the phone so much, but it's a lot of really good stuff. So thanks, everyone. Thanks, Bruce, and thanks, Alexa. And ciao to everybody else. And thanks for being with us.